All right, that's great. We will go ahead and get started. I'd like to welcome everyone. My name is Dr. Anita Murcko. I'm a physician and clinical associate professor of biomedical informatics in the College of Health Solutions. And I'd like to thank you on behalf of our panel today for joining the Health Talks webinar. This is brought to you by the College of Health Solutions at Arizona State University. The College of Health Solutions addresses the challenges facing people and communities to stay healthy, improve their health, and manage chronic disease. These health talks, and this is the last one today of this semester, are one way that we serve the community with timely and relevant educational content and provide continuing education credit at no cost. Right now, before we start, we have a few quick housekeeping items. First, as you know, this session is being recorded and it will be posted on our website, which you'll see in the chat, asuhealthtalks.com. After each of our panelists present today, I will be moderating a question and answer session. So please use the Q&A feature and not the chat box, Q&A feature for your questions. Finally, you will, at the end of the session, receive a brief survey asking for your input about today's webinar. If you are requesting continuing education credits, you must complete the survey to receive those credits. If you did not apply for any continuing education credits, we still would like your feedback. So when you receive the survey, we appreciate if you would complete it and return it. And if there are any questions, you can hear us and see us just fine. I'm going to move to our slide presentation to support today's topic. So just give me a moment here. And is everyone able to see our slides? Yes?
Yes, that looks great.
All right, thank you. All right, so as you can see, our topic today is using big data to improve population health. Joining me today are a few of our fantastic researchers at College of Health Solutions. The first is Dr. Mariso Domino. And Dr. Domino is a health economics professor and the new director of the Center for Health Information and Research at the College of Health Solutions, otherwise known as CHEER. Dr. Domino has extensive research experience in applied econometric analyses and has worked extensively with large databases from a variety of health insurance programs. She has considerable experience extracting measures of medication use and adherence, quality of care, utilization, and cost from a large variety of data sources. Dr. Domino earned her PhD at Johns Hopkins University and then did a postdoctoral fellowship at Harvard Medical School. She moved to Phoenix just this year after a long and distinguished career at the University of North Carolina at Chapel Hill, where she served as professor and director of the program on mental health services and systems at the Cecil G. Shepps Center for Health Services Research. So welcome, Dr. Domino. Following Dr. Domino, we will hear from Dr. Valentin Dinu. Dr. Dinu directs the Translational Bioinformatics Lab at ASU's College of Health Solutions. He holds a PhD in computational biology and bioinformatics from Yale University and an AB in mathematics and physics from Harvard University. He also worked in industry prior to joining academia, where he was a quantitative financial modeler, software engineer, and a consultant. Dr. Dinu teaches courses in translational bioinformatics, research study design, medical decision science, biostatistics, and data mining. Through his research, Dr. Dinu analyzes data for various diseases, including cancer, diabetes, obesity, Alzheimer's disease, schizophrenia, and age-related macular degeneration. We are very fortunate today to have both of these leaders to discuss their research at the College of Health Solutions. To get started, though, I want to make sure that we're all on the same page. So I'm going to give you a couple of basic definitions and terms. First of all, we want to make sure that big data is something that comes from all parts of the body. So as you see from the left side of this slide, big data can be microscopic in molecules and cells. It can take the form of organs and tissues or information from organisms like the human being, and also populations. If we think about how these are divided within the discipline of biomedical informatics, we have very specific titles for these different areas. So bioinformatics, which Dr. Dinu specializes in, focuses on the microscopic, the molecules, the cells, the genomes, all the omics. As we move along the spectrum of big data, we have imaging informatics, where we are able to focus on organs and tissues. Then we move into clinical informatics, and many associate this with electronic health record data, data from individuals, the individual organism. And then finally, population health informatics, which focuses on populations and their environment. And this is the area where Dr. Domino focuses. Very specifically regarding population health, we are going to use the standard classic definition, which is health outcomes of a group, individuals in that group, including the distribution of outcomes within the group. Many people will use public health as a synonym for population health. We consider public health to be a much broader term, and our discussion today will be population health in the focused definition that we are using here. So how about the definition of big data? Big data is a buzzword, and most of us are familiar with the fact that it means extremely large sets of data. These data adhere to a number of attributes, and depending upon whose definition, these are often referred to as the 3 V's or the 4 V's or the 5 V's. And in fact, there's a paper recently published that's about 14 V's. But in general, big data adheres to high volume, high velocity, high variety, high veracity, which means we can trust the data, and then it proves its value. The big data definition also includes data where the traditional data processing methods are inadequate. And you'll hear a good deal more about the approach to big data analytics in the next few minutes. But we need to make certain that we are looking at big data in a way that allows us to evaluate it for patterns, trends, and associations. Big data in healthcare takes many different forms, and you will hear from our 2 speakers today on research that combines health records, genomic data, all the way up through imaging devices, wearables, and actually uses data from other sources that are considered non-traditional healthcare data. So with that, I will turn the podium to Dr. Domino. Dr. Domino.
Thank you, Dr. Murcko. Good afternoon, everybody. It's a pleasure to be here. As Dr. Murcko said, I am fairly new to ASU. I just started this January and have had the privilege of becoming the new director of the Center for Health Information and Research, or CHEER. And CHEER's mission is to be a community resource and a partner for organizations and individuals providing comprehensive information, data analytics, and reporting for all types of uses. So CHEER is very firmly established in the College of Health Solutions, but really belongs to the community of the residents of the state of Arizona. And so it was a center that was established long before my time at ASU in the early 2000s out of projects that actually began in the early 1990s. So it's a center that's been around for a while. It's evolved quite a bit, and it's just been an amazing resource for the state of Arizona and for ASU. And CHEER's specialty is in using big data sources to generate insights on health and healthcare in Arizona. Next slide, please. So here's just a snapshot of some of the data sources that the experts at CHEER use. I won't read all of them, but there are a number of health data sources that can be used to generate all sorts of insights about how healthcare is delivered, how it benefits individuals, how patterns of services are organized, et cetera. And so we can combine those with lots of different forms of other health information, so health records, criminal justice, because there's important insights that we can gain by linking data sources such as criminal justice use to health records, as well as regional or environmental variables like social determinants of health, or as Dr. Murcko mentioned, some of the non-traditional sources that we know strongly influence health, but aren't considered under the domain of health. So for example, the walkability of a neighborhood is something that helps promote health in individuals, although we don't think of sidewalks as necessarily being a public health under the public health umbrella. And so, you know, with these data sources, we know a lot about the characteristics of individuals. We know a lot about the geography of Arizona and where the health services are located. And there's certainly a very large effort on secure storage and processing of these health data and on voluntary data sharing partnerships at CHEER. So again, I won't read this slide. I know there's a lot going on here, but here are just some of the types of analyses that we use to conduct analyses on big data. And so this area is often referred to as data science. And so we talk about data science and analytic capabilities, which includes everything from sort of basic statistics that you probably all took at some point in your career that help us test hypotheses that we may have about data. We can look at trends over time in how diagnoses, for example, develop, or how the kinds of health services people use progress over time. We can look at regional information to see what kind of variation there is across small, neighborhood level variation, as well as large geographic areas such as counties or even the state. We can look at social network analyses, so how individuals, and those could be patients, those could be providers, interact and learn from one another. And then we can use all sorts of advances in health analytics. So you've probably heard about data mining and machine learning as two sort of methodologies that we can use to gain more insights on large data. Next slide, please. So there are a lot of solutions that we can generate from big data. So primary care providers is one example. If they have access to very timely information about where their patients are, they can know as soon as they're admitted to the hospital and start planning for post-discharge care, which is an important gap in some of the data availability that has plagued the healthcare system for many years. In addition, we know a lot about what high quality care is and how we can measure it. And so we can use big data sources to track the quality of care that's delivered in different health systems and to different individuals to identify where improvements can be made in the quality of care and in the equity in terms of delivering high quality care for all. And then one of the areas that I'm really passionate about is linking big data sources. So big data sources in isolation can be great at generating insights, but when we can combine sources across settings, we can even generate more insights. And so I mentioned, understanding neighborhood characteristics and health. That would be two sources of data that we could link together. Environmental data. So there's a group of researchers at CHS who are very interested in heat and healthcare. And so understanding when heat waves hit in certain parts of the state, how that affects health of individuals. And so that's, we can generate a lot of information by bringing together environmental data, based on location and date and time, combined with healthcare utilization during those dates and times. And so that can be information that can help us understand better whether treatments work better in different settings. And in addition, if there's local or environmental factors that combine to create unique health risks or benefits. So I'm going to give you 3 very specific examples of projects that use mostly linked data, but certainly large sources of data, again, to ask and answer specific questions in healthcare. So the first one is a study that was facilitated by CHEER several years ago, brought together climate data on heat events with hospital discharges and even mortality information in Maricopa County, and identified temperature ranges that were associated with increased mortality and hospitalization. So not just spikes in temperature, but sort of duration of high temperature events can be something that's predictive of mortality and of hospitalizations. And so this is a study by some ASU faculty who investigated that using a big data source. This is a study that I was involved in, and we use linked data from Medicaid, from a statewide mental health system and the prison system in Washington State. And we examined whether Washington State's new policy at that time of expediting Medicaid enrollment, and I'll explain what that means, for people who have a severe mental illness and were incarcerated and then released from state prisons. And so the expediting comes from the fact that when people are incarcerated, they typically lose their Medicaid coverage. And so often once they're released from prison, it can take months, if not a year or more, to regain their Medicaid coverage. And during that time period, that can be a particularly vulnerable time period because they may not be able to afford medications and mental health treatments that are essential to them for their care. And so we examined Washington State's new policy of expediting Medicaid, working with people before they were released so that the day they walked out of prison, they were able to have a Medicaid card in hand. And so we looked to see if that affected their ability to access mental health services and whether that also affected their criminal recidivism or their, being re-incarcerated for another crime during the year. Next slide, please. So what we found here, the pluses mean that the use went up. So, oh, sorry, there might have been a slide before this one. Oh, okay. We will go here. So these are health services that we found. So by expediting Medicaid, we found people were more likely to receive community mental health care. They were more likely to receive appropriate medications for their conditions. They were more likely to receive medical care and even emergency care, because that can be important too. They had no effect on the state psychiatric hospitalizations and really no effect on arrests, although we did find that among those who were arrested, we found slightly longer jail and prison stays. And we did look at that further in another paper that I can certainly point you to. Next slide, please. So the final example here is a study that, again, uses linked data from Medicaid, from a statewide mental health system and the prison system in Washington State. And we examined whether Washington State's new policy of expediting Medicaid, working with people before they were released so that the day they walked out of prison, they were able to have a Medicaid card in hand. And so we looked to see if that affected their ability to access mental health services and whether that also affected their criminal recidivism or their, being re-incarcerated for another crime during the year. some of our staff at CHEER worked on, and it's through a mechanism or a project called Eyes on Learning, which is about advancing children's vision health. And so this was a statewide initiative to look at the proportion of children at different age groups who were receiving vision screening and eye exams, as well as follow-up exams after well child exams or eye exams. So let me just give you a quick snapshot of some of the study findings. So here you can see that the rate of vision screenings was only about 46%. So that's a 45.93% in the top left-hand corner here. And there was considerable variation by age group, with some of the younger kids getting vision screening more often than older teens. And again, considerable variation by child, race, and ethnicity. So this was important information for the state, and again, a way to use big data to try to improve these outcomes and understand where there's room for improvement. Next slide, please. So in summary, analysis of big data is essential in healthcare. Many researchers at the college and at ASU and around the world are actively using big data to accelerate advances in healthcare. And by linking multiple sources of big data, that leads to even further insights across healthcare settings. So with that, I'm going to turn things over to Dr. Dinu.
Thank you very much, Dr. Domino. So my name is Valentin Dinu, and I work in translation and bioinformatics here at the College of Health Solutions at ASU. And I will start with some of the challenges that we encounter related to big data. So obviously lots of sources in the healthcare domain that are generated tremendous amounts of data. And some of the biggest challenges, immediate cost and time related to managing, integrating, securing, analyzing this data in a manner that can be used for analysis. So those are two of the biggest constraints that we have. And on the next slide, we highlight some of the informatics aspects that are more related to the data analysis itself. So just having the infrastructure access to large storage facilities for storing petabytes. You heard earlier from Dr. Murcko, exabytes of data. Luckily, we don't have that, at least in my lab. That would be very, very expensive. So not only expensive, but also hard to manage, to maintain. Talking about large facilities that would store such amounts of data. And also the standards for harmonizing, integrating many of these data sets, they might not be always developed, available. They are still being developed for many of the biomedical domains, ranging from the omics type of data all the way to clinical, to population health. So that's still work being developed. And at the end of the day, do we have access to good platforms for sharing these large data sets and enabling researchers and facilitating various type of questions to be asked from this data to improve healthcare. And on the next slide, I have what might be potential solutions that have been adopted in the context of the National Institutes of Health. And this is, I'm highlighting here a website that is pretty much considered a gold standard for cancer genomic research in the cloud, Genomic Data Commons. And they use behind the scenes, actually, they use cloud computing technology. So actually, much of this data is stored in Google Cloud environments, AWS, Amazon Web Services, Microsoft Azure, and so forth. But they create a layer that is specific for managing, integrating, analyzing biomedical type of data. And overall, this creates an environment that brings data closer to researchers for analysis. They don't have to invest in storing this data locally. You can just bring your own tools for analysis in the cloud and access data that simply regular researchers will not have access to bring locally in their labs at their institutions. And I have here a screenshot taken from the Cancer Genomics Data Commons taken this morning. So we have about 70 projects right now. If you work in cancer, you might have heard of TCGA, the Cancer Genome Atlas, Target, which holds pediatric cancer, and many other projects. Potentially, if we have time and interest, we might do a quick browsing through this great cloud-based repository in the Q&A session. And we also were going to highlight a brief project that we used in my lab for analysis of this cloud-based data repository. Thank you. And just to highlight the type of usage that this type of cloud-based repositories get. So you have here on the purple at the bottom a lot of downloads from all around the world. North America, Europe, Asia, everywhere, and a little bit harder to see. There's a green line there that would be data uploads. So there is data being uploaded there. You have petabytes type of data, which is, a lot of data made available, but at the same time, just looking at the scale for download going down, a lot of usage from many users around the globe. And I actually wanted to mention that this is one of the more, let's say, used and gold standard, again, projects for cancer research, for cloud computing related to the NIH Commons. When it launched actually in 2016, at the time, Vice President Biden was actually part of the ceremonies, took part in the ceremonies for launching this repository for cancer researchers around the world. So it's very, very much used still nowadays and being updated. And when it launched only with about 30 projects. Now we have more than 70, and there are close to 100,000 individuals with a variety of data, genomics, transcriptomics, and so forth. So I'll come back to GDC later on, and moving on to the next slide. Some of the benefits of sharing data in the cloud. I have several bullet points here. So first of all, we want to speed up the rate at which we are doing discovery in the healthcare. So by making this data available, we can analyze it. So not only the researchers who generated the data can generate results from this, analyze it, but also anyone around the world. So it's publicly available with some thresholds for privacy and security, depending on what type of data one wants to access for analysis. At the same time, an important concept in biomedical research is, can this the findings that scientists publish, are they reproducible, repeatable, and can this be trusted as a source for advancing the science? And at the same time, a very important concept I was mentioning earlier, that one of the first stated goals of GDC was to bring this close to 100,000 cancer genomes, very well annotated, and we are very close to that. I think we are close to around 90,000 in the GDC repository. And some rare conditions, especially some pediatric cancers that we also worked on, they could be rare, and it's much easier to collocate data from different projects and create the analytical power that enables the identification of smaller effects, of rare variants, and other biological potential dysfunctions that might be involved in a disease. And on the next slide, I have additional benefits for sharing data. Again, cost is an important aspect here. How can we enable researchers to do research without spending a lot in infrastructure, in having data? Again, I have access to tens of terabytes of storage, for example, in my lab, which is quite large, but I would not be able to analyze petabytes of data to bring it locally. So I'm fortunate that this resource exists in the cloud for us to analyze and do a comprehensive analysis, for example, and this by creating an environment for disseminating this data. This is very beneficial for researchers. At the same time, individuals might develop their own tools for analysis, and you can also bring your tool in a cloud environment and make it available to other researchers to combine with this very rich data sets for analysis. One aspect that many people have in mind when talking about big data and data in the cloud, how secure it is. And this is indeed actually a good concern, but generally I think it's actually easier to secure it in the cloud than in physical storage for most environments. And these are very secure, and NIH went through a lot of steps to certify to ensure that data is, for example, secure. And we have this as an example now. It's been running for 6-7 years, this GDC, and there are many other projects now moving into the cloud, all of us and others, that create a very safe and secure environment for data, which enables individuals to share their data that might be otherwise considered private for research, for enabling large-scale research. And overall, the broad impact that such environments create for tools, for analysis, and so forth. So moving on now to some specific examples. So FAIR wanted to highlight that findable, accessible, interoperable, reusable, if you've done research in the context of NIH, big, let's say, concerns and things that we want to enable for research. And moving to the next slides, I have a couple of examples. And again, cloud and pilot projects that are available. And we can go to the next slide for research. So two projects that I want to highlight that we have done using this type of data. So analyzing, creating a pan-cancer analysis for non-coding RNAs in cancer. And I had a seminar a few months ago for Cancer Genomics Cloud, where we presented to researchers around the world, our researchers. So on the next slide, we have actually some of the workflows that we created in the cloud. So just high level. So POTRA is a tool that we developed in our lab. It's an R package, but we first analyzed some subset of GDC data for liver cancer in our lab, but we couldn't analyze the entire data set, and we're able to actually upload our tool in the cloud environment and do a pan-cancer analysis, analyze dozens of samples, dozens of cancer types for analysis, and the manuscript is in preparation. And at the bottom, we have some pipelines for workflow for analysis in the cloud. And the next example that I want to highlight, and closing the circle now back to CHEER, we have been fortunate to collaborate with researchers from Mayo Clinic and CHEER on analyzing racial disparities for gallbladder cancer, which has a very high, higher incidence in non-Hispanic whites, American Indians, and Latinos. And some of our goals on the next slide, we highlight what our aims of the research would be for identifying risk factors related to racial disparity, and analyzing metabolites and genomic data as well. And again, this is in collaboration with CHEER, so this is directly supported by Dr. Domino's group that presented earlier. And on the next slide, I have as an example, if you've done genome-wide association studies, you're looking here at millions of genetic variants going from chromosome 1 all the way to 22 and X and Y. And this is quite an exciting result to see that, that we had some variants that crossed that, or are right on top of that significance level on chromosome 8. That's generally a very good result, and we're in the process of confirming this with other data sets. And again, this is enabled by large data sets for that are available for us in cancer genomics. And I will end up with acknowledging some of the resources that we had for these slides. So the GDC inspired by Bob Grossman, who's the PI of GDC, and researchers from NIH. And Margaret is a collaborator who worked on the GDC project in the cloud, and also other researchers from Mayo as well, and ASU. And thank you.
All right. Thank you very much. And I'm going to ask Jackie if there is a different slide that you would like us to use at this moment.
Go ahead and take down your screen so everybody can see all three of your faces.
Okay. All right. So I think that we're going to proceed now with our questions and answers. And we have a couple of questions in the queue. The first question I would like to direct to Dr. Domino. And this is a question that specifically asks if there are data projects for breastfeeding surveillance in Arizona. And I think that this kind of kicks off a discussion of what is the range of projects and how data becomes analyzed at CHEER. So could you talk about that in the context of this question?
Sure. So I can answer this, but Dr. Murcko, I may pull you back in because Dr. Murcko has also been with CHEER for many more years than I have. And so she has expertise that I am still trying to acquire. The short answer for this is that we tend to use health insurance sources of data and what are called administrative sources of data. So data that are kept in records. And breastfeeding is challenging to get from health insurance records because it's going to be very undercoded in a lot of health insurance records. So that being a major source of data for CHEER means that we may not have the great data that would provide nuance on, whether birthing people are breastfeeding, for how long, that kind of thing. So let me actually turn it back over to Dr. Murcko and see if maybe you know more of the projects that may be in this space.
Let me first say that the projects are ranging from those where CHEER has special interest based on the longitudinal data sets that it maintains. So CHEER has about 15 years worth of longitudinal data from Access. And one of the special things about the Access, the Medicaid data that we have in our state, is that the individual, whether they're in and out or in different health plans in Access, you maintain the same Access number. So information can be linked. And Access has a very special relationship with CHEER in that all of that data from the last 15 years from the Access claims are available to individuals, researchers who would like to use these within the process. So there is a very special process for making certain that the data is secure and used in a way that's going to benefit the society in general, so that we do good, solid population health research. The data from other areas that Dr. Domino was mentioning can come from any agency. It can come from claims, it can come from electronic health records, and it's very specific to the project. CHEER works with researchers to identify their particular outcomes and to figure out which data sources would make the most sense for their project, and can also help with the processing of the data. that can make the project have the best, most successful, and most efficient outcomes. So, so right now, to go back to that question, breastfeeding surveillance is not something we're studying, but if you have a project and you have an idea, I know that Dr. Domino and all of us at CHEER would be more than happy to help structure a project that would help us gain insight into breastfeeding in Arizona. Any other comments, thoughts about that? No? Okay. I see a question here that's really going to be great for both of our panelists, since you look at data from various ends of the spectrum. And that's from Julie Malloy, who wants to know, how do you envision data interoperability advancing in healthcare over the next few years? So Dr. Dinu, I'll ask you from your standpoint, how do you see interoperability advancing and advancing the research that you're doing?
Thank you. Yes, that is a very good question, and that builds on the creation of first data availability and at the same time data standards for exchanging, integrating, and having access to data that's in a format that can be analyzed. Talking about specific impact for clinical care, population care, to what degree, if we want to integrate, for example, precision health type of data such as genomics or wearables, how can we integrate that into the clinic? And we collaborate with researchers from Mayo Clinic who are actually working on this type of initiatives where they look at genomics sequences in the context of cancer, or TGen, Translation Genomic Research Institute, working, for example, on pediatric cancer. They have had some great success stories. So we are still working on developing this infrastructure for data sharing, for standards, but there's only one way to go forward, and that's the future of using more data towards precision health for the individual and for a population enabled by data.
Thank you. Dr. Domino, do you have any thoughts about that topic?
Sure. So I think, one of the advances that I think is certainly not, something that we've been working on for a while is allowing patients to have portals into their own data and to even contribute data. So, if you wear an exercise watch that keeps track of your steps, or maybe even your time if you're a runner, or heart rates, those are things that actually can be added or combined to the health records that we see. And so patient generating notes, comments about how they're feeling, we have that capability now through some of the electronic health records, but I think not very many of us are taking advantage of that. And so I see, pretty big growth in that area as it becomes easier for patients to not only receive data, their lab results and things that they might find useful, but also contribute data, back up into these data sources that can be integrated. And so I think that's really going to explode, I suspect, over the next few years and be an amazing additional resource for researchers who are looking to combine, extra information that we currently may not have in those records. And so that's one area I think that we'll see, certainly other advances that again are nothing new, but, maybe are still in the steep part of the learning curve. Things like data visualization. How do we, in a very simple and straightforward way, convey the complex relationships that we often see in big data? And I think, again, there's been big strides in that, but we'll probably see that continue into the future.
Wonderful. And just to cap off that discussion, some of you may have heard of the 21st Century Cures Act, which was passed in 2016. There are very specific regulations that are coming to fruition in this year and next year that place some very specific standards for individuals that are generating data. Vendors that create electronic health records, for instance, will need to adhere to these standards. And I'm certain that you can't be in healthcare without hearing about information blocking And information blocking is this interoperability of electronic health records that the 21st Century Cures Act has as its goal in setting these standards for vendors and for those exchanging data. So I'm going to say that the data interoperability horizon is very bright. So we will be having more big data that's more usable, and that we can keep Dr. Domino and Dr. Dinu very, very busy. There's another fun question here that I see from Michelle Zimmerman. What are your favorite data sets that you've seen analyzed effectively and made applicable action changes? And I think, Dr. Domino, we're going to start with your favorite data sets that are actionable.
Thanks. So yeah, that's a great question. I love this question. I mean, for me, I am very dedicated to the Medicaid program. It's a program that it's a state-federal partnership, and I think that's very exciting because states have lots of ability to customize the program to address populations in the state, to address issues of importance to the state. And so I love that about the Medicaid program. And it, as a researcher, the variation across states in how they cover services, what initiatives they participate in really gives, lots of fodder to run research questions that may be of interest. So what can we learn from one state that may be applicable to other states? So I'll give you, one example. In my research career, we looked at a policy change that was done fairly quickly in North Carolina that cut the length of a prescription that somebody on Medicaid could fill. They used to be able to fill it for 100 days, and they cut it to 30 days because an administrator somewhere thought that people were filling these 100-day-long prescriptions and deciding within a day or two that, that they didn't like the side effects or would change drugs. And so there was worry about, a lot of wastage in the system. And so we were able to analyze that data on a very timely basis to, in fact, see what happened when they made this policy change. And we actually found that it resulted in higher, not lower costs, because the Medicaid program has to pay a dispensing fee to pharmacists. And so for people who were on chronic medications and stuck with those medications, they then had to go back to the pharmacy every month instead of every 3 months. And the Medicaid program had to pay the pharmacists a dispensing fee every month instead of every 3 months. And so the amount, we were able to estimate the amount that was saved from, potentially not using a long prescription versus the amount that was generated from these additional dispensing fees, and found that the policy was not at all cost effective. And so we were able to present those results to state decision makers, and they quickly changed the policy back. So I think those kinds of analyses with Medicaid programs can be very impactful.
Well, that's a great answer. And I think that Dr. Dinu said a picture's worth 1,000 words. So he's going to show his favorite with a quick demo, I think.
Thank you. Yes, I will definitely want to do that. Thank you, Anita. But just before I go into that demo, I wanted to add my thoughts to that good question that we got earlier. How can you not say something about your favorite data sets that you're using, and especially after Marisa's mention of drugs? So I want to talk about pharmacogenomics, actually, and PharmGKB, which has been a great resource. And I like it also for actually 2 reasons. First, the week when I joined ASU, actually back in 2007, FDA came with the first FDA recommendation for pharmacogenomics for a drug that was warfarin. And since then, there have been dozens and more than 100, hundreds of drugs that receive pharmacogenomics type of recommendations. So that's something that immediately impactful, and some of this precision personalized research that can be done analyzing some of these data sets. Also has a personal note. Actually, my wife is a pharmacist, and actually she uses some of these resources for counseling patients, for figuring out drug interactions and other things. So wanted to talk a little bit about the pharmacogenomics. And if we have time, I would love to give a brief demo, as Dr. Murcko mentioned about GDC, Genomic Data Commons. So is it okay to move on to that, Dr. Murcko, or do you
Yes,
need to
please. Yes. Yes.
Sounds good. Then I'm just going to share my screen.
Yeah, it's not something that we think about every day, and probably would never go there. So, so this is one great opportunity for everybody on the Health Talks today.
Perfect, thank you. So just to confirm, you can see the GDC data portal on my screen. Is that what you see? Yes. Thank you. So relatively easy to find it, GDC Cancer, and that's the first portal that comes to you. So it's built by and hosted by NCI, National Cancer Institutes. 70 projects of what would be probably the best annotated and the gold standard cancer used in cancer genomics research, starting with the TCGA, the Cancer Genome Atlas, Target, pediatric cancer. We've been using various projects from here. You can look at them based on location of cancer, which organs. You can also look at the source of the data. For example, we've been working with this also with researchers from PGEM, for example, and Mayo Clinic. We've been working on multiple myeloma. And on this COMPASS data set, you can see various types of data that are available, RNA, so gene expression, whole genome sequencing, and others. Various type of categories that were including both from specimens, but also clinical type of data, genotyping array, sequencing, methylation. I also have here, well, usually before we go there, wanted to highlight some of this concept of data security in the cloud. So here we're talking about petabytes of data, hundreds of thousands of files. These files are huge. If you work with genomic sequencing data, you're talking about gigabytes and gigabytes of data per file. So these are, tremendous amounts of data. The concept of controlled and open. So you see here roughly about a third are open, so are available for someone to just browse and download for analysis. Some of them are controlled. And that means that usually there's the type of genomic low-level information might be sequenced, or you might be able to identify variants at the genomic level. And that has some levels of protection where in order to have access to it, you have to request access to this controlled data. So to preserve some of the privacy of the individuals, I will have to submit a request through, in this case, being affiliated with ASU, I submit a request through a portal with the database dbGaP or with GDC data portal, but really takes us to dbGaP, which is a database of genotypes and phenotypes. They control the access, and then that becomes available for me, for us, for a researcher to analyze. And you can see here on the right, some data files are controlled while some are open. For example, an open data file access might be gene expression. That's a number that's quantified by counting the number of, let's say, sequencing and aligning to a region in the genome, while controlled maybe it's a piece of DNA that might give you ability to say this particular individual, they have a BRCA mutation at a certain point, but that also could be inherited. So that could raise potentially some privacy concern. Now, once I request access to data, and I have to specify and promise to be nice, right? And say and use the data securely, either if I download it locally, but I can also analyze it in the cloud. In this case, for GDC, we said we want to analyze it in the cloud. And I'm going to shift screens here, and I'm going to show you actually how we analyze it in the cloud. So this is one of the free cancer genomic pilots. So it's CGC, Cancer Genomic Cloud. It's actually a commercial entity that created together with NIH, an environment and a cloud where we could bring our tools. For example, we brought POTRA, our tool that we developed to analyze, to perform this analysis in the cloud. As you can see here, some of the data, some of the projects use control data, while some others might be using data that's publicly available, that's open. We can launch them using flexible servers in the cloud for analysis. So this would be what it looks like on the cloud portal when we launch some of these jobs, and some of them go in a batch, some complete, and you get reports and everything. So that's how we perform some of this analysis. And that's a brief demo of these cloud environments for analysis, and I wanted to highlight.
So Dr. Dinu, just to kind of sum up, can you let folks know who would access this type of database and for what purpose?
So we access this data as biomedical research bioinformaticians who develop tools and want to analyze some of these great data sets in the cloud. At the same time, there are also portals made available for people who are not necessarily researchers, but maybe they want to do some browsing and analysis of data in general and get trends or health information. And actually, since I can, and I started that, I'm just gonna talk about all of us. So all of us research workbench. So this is, some of you might have heard about an initiative to genotype more than 1 million individuals in the USA. So again, various level of data protection, but this is also targeted for people who are, not necessarily very knowledgeable about informatics or genomics, but they want to understand some of the research being done for various diseases that would be of interest, and what type of data are being used, what type of conclusions, and even be part of this research by contributing and being part of all of us. Thank you. Great question.
So we have a wide range of uses of our big data just within College of Health Solutions. To kind of close our discussion, Dr. Domino, can you give us a brief summary of what type of training students might want to approach so that they can get into big data?
Great question. I think that, I would think of that in two dimensions. One is certainly as students, I think, putting as many tools in your toolkit is a great thing to do while you're a student. And there's certainly a lot of technology to learn to analyze big data, everything from the environment in which big data sources are housed. So Dr. Dinu talked about cloud, storage solutions, as well as some of the server kind of based storage solutions that we have. So understanding how those work, how the software packages that we use to analyze data. Again, Dr. Dinu mentioned R is certainly one of the workhorses, and there's lots of other options for statistical analyses. So I think learning those as soon as possible and as often as possible is certainly a great option, as well as being involved in research projects. So I would say find the faculty or the researchers around who are doing the kind of work that you want to do, and start asking if there's opportunities to help work in some dimension on research projects, just to get that experience.
Well, that is a great summary. And I think that unfortunately, that's all the time we have for today. I do want to encourage all of you to follow the College of Health Solutions on social media, and you'll see the many options that are available on the screen, because we want you to learn about all the other opportunities that are available, just like this one. This is the last health talks for the semester. We'll take a break for the summer and resume Thursday, August 25th at noon Arizona time. Details and registration will be available at asuhealthtalks.com. And on behalf of the panel, the College of Health Solutions planning team, and the College of Health Solutions, I want to thank you so much for joining us today, and know that big data is in your future, and it's a bright one. Thank you, everyone.
Thank you.